Esteemed guests, ladies and gentlemen, on behalf of Stellenbosch University's Rectorate and the Faculty of Medicine and Health Sciences Management team, we'd like to welcome you to the esteemed occasion of the inaugural lecture of Professor Regan Solomons. We'd like to remind you that this event is being recorded and we ask you to switch off your cell phones now. Please rise as we observe the entrance of the academic procession.
Please take your seats. Good evening, colleagues, ladies and gentlemen. It's my great honor and pleasure to welcome you all on behalf of Stellenbosch University to this very significant occasion, the professorial inaugural lecture of Professor Regan Solomons. For those of you who don't know me, my name is Nico van Pittius. I'm the Vice Dean for Research and Internationalization of the Faculty of Medicine and Health Sciences of Stellenbosch University, but I'm also the acting Dean since Professor Elmi Miller, our Dean, is currently abroad. She sends her apologies and asked me to convey her heartfelt congratulations to Professor Solomons. A warm welcome to all friends, family, and colleagues of Professor Solomons who are with us tonight, either in person or online, and including colleagues from Stellenbosch campus and our esteemed guests from outside the university. And a special word of welcome to Professor Nico Koopman, our Deputy Vice Chancellor for Social Impact Transformation and Personnel, Dr. Renel Retief, our Registrar, Professor Solomon's wife and children, Galen, Nicholas, and Celine, his mother, Audrey Solomons, his parents-in-law, David and Felicia Rode, his brother-in-law, sisters-in-law, nephews, nieces, and the rest of the family. Welcome to all of you. The head of Western Cape Department of Health, Dr. Keith Kluter, and his wife Estelle. The CEO of Red Cross Hospital, Dr. Anita Pabu. The head of Pediatrics, Red Cross Hospital and UCT, Professor Rizani Muloiwa. And our colleagues from the Tygerberg and Red Cross Hospital Management. And then, of course, our inaugural lecturer, Professor Solomons. Regan, welcome. Our colleagues in the faculty and in the university know this very well, but to our visitors and family, it is important to note that the holding of an inaugural lecture for a person who became a full professor is really an age-old tradition in universities. It has transpired countless times over hundreds of years in all universities in the world. These events hold a central and significant place in all universities, including ours, calendars. They mark this key milestone in an academic's journey, this one special moment when the scholar, researcher, and educator is formally recognized for what is mostly their lifelong contributions that have earned them the title of being a full professor. This occasion allows the individual to profess as a professor, in other words, to share their academic pursuits, their research interests, their passions, their contributions to their field with the university community and the broader public, and with their family, very important, the people who have supported them over many years. It also offers a rare opportunity for the audience to glimpse the character of the person, the path that led them to this remarkable achievement. Today we gather to celebrate not only Professor Solomon's impressive accomplishments, which have earned him the distinction of full professor, but also to honor his intellectual curiosity and his academic excellence, which also embodies what our institution upholds. As such, it's a very special occasion for us, and we are thrilled that you have chosen to join us in celebrating this important event with Regan. Please allow me a brief moment to introduce the candidate, Professor Solomons. Regan Solomons is a pediatric neurologist and a clinician scientist, and the executive head of the Department of Pediatrics and Child Health at Tygerberg Hospital and the Faculty of Medicine and Health Sciences at Stellenbosch University. He was born and raised in Cape Town and obtained his undergraduate medical degree from the University of Cape Town, which we've forgiven him, but that's fine. He completed training in pediatrics and subspecialist training in pediatric neurology at Tygerberg Hospital and at Stellenbosch University. In 2011, he was awarded the Desmond Tutu Vrije Universiteit Amsterdam doctoral scholarship, which culminated in a joint PhD from Stellenbosch University and the Vrije Universiteit in 2015. In other words, 10 years ago. And if I'm correct, that was the first joint degree with Vrije Universiteit. Maybe Mariana can just confirm, but I think that was the first one. So that was a wonderful achievement. That was 10 years ago. His dissertation addressed ways to improve the early diagnosis of tuberculosis, meningitis in children. Very important work which we will surely hear more of today or this evening. His work spans epidemiology, early diagnosis, omics-based biomarkers, and clinical complications and management. And I'm going to leave it to him to tell you all about that. But it is important to note that since then, Regan has authored and published more than 90 scholarly publications in peer-reviewed scientific journals, adding to the 10 papers that he had before his PhD, giving him a total of more than 100 papers. His work receiving more than 2,000 citations by other authors in that time. Colleagues, that's really a remarkable achievement for only 10 years of research since the PhD, especially for someone who's also a clinician and executive head of a large department. He also contributed to National and World Health Organization clinical guidelines. He has co-developed 2 patents for biomarker-based diagnostics with colleagues at the faculty. He's a member of research consortiums, the Tuberculosis Meningitis Consortium, widely regarded as a global expert in pediatric TBM, with work that has shaped WHO recommendations, including the adoption of the so-called Cape Town regimen as an alternative for drug-susceptible TB meningitis in children. He's a product of mentorship in the faculty and is therefore also passionate about mentoring undergraduate and postgraduate students, has supervised and co-supervised many postgraduate students, and continues to mentor a large cohort of pre-doctoral and doctoral scholars. You can read the rest of his biography in the paper, but just to say that that Regan is a scholar, a well-rounded scholar, with many accolades to his name. But we also know that spending quality time with his family is a priority for him. And his extracurricular activities usually revolve around his family, which includes traveling, cooking, gardening, reading, running slowly, he says, and spectator sports. So apart from all of these academic accolades and service that Regan has done over the years, more importantly to me, Regan is just a very, very nice, humble, and friendly human being, well liked by everyone, always friendly and smiling, always willing to engage and contribute. And it's a wonderful testament, Mrs. Solomons, to the type of person who you have brought up. Thank you for helping to shape this human being to the person who is contributing significantly to our institution and society as a whole. Finally, I have it on good authority, and that authority being myself, as I've benefited from this, that Regan is also an avid lime grower. He's got a tree with nice limes on it, and he's always keen to share his crop. He's always keen to share his crop with colleagues and friends. So it would not be strange to see Regan downstairs in the basement handing out white bags of stuff to colleagues from the boot of his car. In the basement, I said. But although this might look and sound very suspicious, I can assure you that everything is above board. These bags just contain a number of wonderful and tasty limes. So given his keen interest in the fruit and the lime's known links to health and wellness, and before I hand over the podium to Regan to give us his inaugural lecture, I thought it would be good to share just a few fun facts about limes from a medical health and wellness perspective. In the 18th century, Scottish surgeon James Lind conducted what is considered the first clinical trial with citrus fruits, proving that limes and other citrus fruits prevented scurvy, a disease which was caused by a lack of vitamin C. From then on, limes became essential on long sea voyages, particularly in the British Navy, which prevented the disease scurvy in the Navy, but earned them the nickname limeys. And that's where the British sailors and later the British themselves were nicknamed limeys. It's therefore not that strange to see a medical professional handing out limes, as this is an age-old tradition. Bringing it closer to home, our medicine and health sciences context, lime juice was used in histology and old medicine to prevent bacterial growth before refrigeration existed. In African traditions, limes is seen as a cleansing and protective fruit used in rituals to ward off negativity. I know we like to see evidence-based medicine in this faculty, and I can really see this works, because I rarely see Regan as being negative. And finally, in art and literature, the lime symbolizes freshness, vitality, and the sharpness of truth as a metaphor for cutting through illusion and vagueness. And we are looking forward to listening to Professor Solomons cut through the illusions with sharpness of his truth gained over many years of hard work. Regan, we're looking forward to your lecture, and thank you very much.
So thank you for the introduction, Nico. I'm not going to do thanks and acknowledgements again, but just to acknowledge Megan Salon and Jonathan Dale Blankenberg that was on my case for the last 2 months putting this program together. And just one disclaimer, where's Prof. Johan Skuman? He actually gave me the lime plant as a housewarming gift, and I don't they died. So yeah, I'm glad to say I'll give you some limes if you need some. So my title: Who is Sugarman and what is Neverland? So I'll give some context. So Sugarman was a song by Sixto Rodriguez, And I love that song since university days. And just looking at the background, he was an icon of the anti-establishment movement in South Africa during the apartheid days. And he was very famous here, he just didn't know it. And there was this rumor that he committed suicide during one of his concerts, and people always wondered, and there were 2 South African documentary makers that went to find him, and he was alive and well in Detroit. Very fascinated that he actually sold some records in South Africa. And myself and Galen, my wife, actually managed to go and see him at a concert at Grand West, and following the tradition of South African concerts, getting artists here when they decrepit. We went to watch. He had to be led up to the stage, but his fingers on the guitar, just a genius. And then Neverland, we all know the story about Michael Jackson. It's actually a movie about him trying to attain Neverland, which is eternal youth, Peter Pan and Captain Hook, and not finding it, maybe due to using the wrong sort of medication. But yeah, still the search for this sort of unimaginable idea. So a bit of background about myself. So I'm going back to my grandmother's roots. So this is me and my grandmother, Philomena, Africa. I'm from Genadendal. That's where my roots are. This is in the front garden. And the church in Genadendal, it's a Moravian church. The town was established in 1737. It's really old, really good things. Sort of really innovative things have come from Genadendal, and that was suppressed during the time of apartheid, and I don't think the town is quite recovered. And this is the view of the mountain. It's called Grootkop. This is from the driveway of my grandmother's house. That's now owned by my Uncle Kenny and Auntie Trudy, and I still have a room to go there. I should go more often, but you really get this sense of peace and grounding when you go there. And this is my other grandmother, Sarah Solomon's surname was Willemberg, and she gave me this book. She actually took it out on lay-by with her pension money, and I didn't know about it. So at her funeral, unfortunately, in 1991, one of her friends gave this to me and told me that your grandmother left this for you because she knows you want to do medicine one day. So the spine is broken inside. I mean, the content is not great, but the book still has pride in my bookshelf with lots of expensive books, because this is just somebody rooting for you, for your path, and kind of knowing the path that you're going to take before you even know it. It's my family. Top photo on the left is myself and Galen, my 2 brothers, Don and Chadley. Chadley is here, Don is online, and my dad, Cyril, and mom, Audrey. And my dad joined me for my defense in Amsterdam and for my graduation at Stellenbosch. He passed away in 2018, and really so much that sort of the brothers have inherited from him, and I can see him in the grandchildren as well. And my mom, just for always being there, being our top supporter. I see the photos cut off halfway, but that's our bigger family, and Zaki came afterwards. Zak's 2 years old. He turned 2 on Saturday or Sunday, but we are 3 brothers, and yeah, there's, let me count, 1, 2, 3, 4, 5 grandchildren, and all of them have professed no more grandchildren, so my mom has to deal with them. Yeah, apologies for the photos that are being cut off. I'm not sure why, but there is one photo, so that's Galen. I'm sure lots of people Galen's like, she's the organizer of our house, and sometimes I let her organize me as well because I'm really poor at organizing. And Nicholas and Celine, and this is my team. Love them lots. I support them to the hilt, and they support me as well. And this is my extended family. These are my in-laws, and at every birthday I used to get really irritated at the beginning in my little townhouse because we always had 40 people coming for birthday celebrations. But it's just part, the family is always there with every occasion, and just this is to acknowledge them as well. Oh, this is probably big and important photo to show, but I'll tell you about it. I don't know why it's not projecting from the laptop. So this is a photo from our 2023 reunion. So my great-grandparents were Marcus and Benigna Klute from Genadendal, and there's 7 branches. And I'm from the Africa branch, and Keith is from one of the Klute branches. And we've had now 2 reunions. We'll have the next one next year. We have it in Genadendal, and more than 300 people come to our reunions for the whole weekend. So I'd like to say all invited, but there's always place for more, and there's lots of fun and connecting with each other, and that is my roots and where I come from. And apologies that the photos aren't showing. So back to tuberculosis. So there is some evidence of central nervous system TB in antiquity. So this is a photo from the inside of one of the tombs showing a boulder with a Afrikaans word is a bochel, a kyphosis, having spinal TB. And there's some Egyptian mummies that date back to 2400 BC with typical skeletal deformities of TB. And Hippocrates, he had the first description of brain TB, and he called it dominated by headaches, fever, and altered consciousness, and it could be describing one of our patients that we have currently. In the 17th century, Thomas Willis described TB as sometimes headaches, fatal and incurable, and abscesses follow and swellings follow the envelopes of the brain as well as tubercles. Death occurred after a state of lethargy and prolonged fever, and on post-mortem, he observed inflammation of the meninges, dilated brain ventricles, and tuberculomas compressing the brain. In the 18th century already, John Paisley described a 7-year-old child who died after a prolonged state of lethargy, fever, and coma. And on post-mortem, the ventricles were distended by water. Robert Hooper, also in the 18th century, depicted purulent basilar meningitis, and the picture on the bottom right is a picture of this exudate that causes all the damage in tuberculous meningitis. In the 19th century, John Abercrombie, he localized TB to the base of the brain, and Louis Sen, also in the 19th century, described chronic tuberculous meningitis occurring in children. And then and now to the 20th century, I've forgotten, we're in the 21st. But in the 20th century, Dorothy Price, she described TBM in children as an acute and fatal disease appearing early. The early supervention of the meningitis offers not time for any wasting. Waxman identified streptomycin, and after this discovery, half of TB patients recovered under this treatment for the following 5 years. Jorgen Lehmann, he synthesized PAS, and the British Medical Research Council in 1950 did one of the first RCTs where they looked at a combination of PAS and streptomycin, and they found it to be more effective in cure and preventing drug resistance. And in 1965, Dennis Mitchison, he recommended initial therapy with a combination of 3 drugs. So all of this was done years ago, and it sounds like descriptions of the patients that we have in the ward, just we have 4 drugs at the moment. So this is an image from one of the records, and just to read you, this is a 10-month-old boy that had loss of appetite, vomiting, irritability, was coughing for a week, had fever and a TB contact, and was pale. The child was slightly irritable, had a bulging fontanelle, and neck stiffness. And at this stage, TB meningitis was queried. In the notes that followed, and I can see my name, and there's a few names of, I think, current fellows. So this patient was diagnosed at TBM stage 2A with basal meningeal enhancement. And this was, you can see on the 5th of December 2016, 10 days later, this patient likely had a brainstem infarction and died on the same evening. And tragically, I mean, this is the description of patients we see in the ward. We see 30, probably 40 to 50 patients every year, and this goes back until 1985, and we haven't touched the incidence of TB meningitis at all. So just some Stellenbosch University colleagues that influenced my thinking along the way. Top left, and this is for Dr. Retief. So Prof. Budgie. Prof. Budgie, he gave me my job as a registrar. I drove through from Worcester on a Friday. I was late, an hour late, because there was an accident just before the tunnel. It was 37 degrees. I was sweating big drops. My shirt was wet. And I was really nervous because I'm seeing the head of pediatrics. And he sat me down in the chair and he asked me in Afrikaans, "Waar kom jou familie vandaan?" I told him, "Kuils River." And he said, "Welkom in die departement senior in January." That was that. And things have changed somewhat. Now there's shortlisting and you need a part 1 and publications and lots of things to get a registrar post. But this just explains really the humanity of Prof. Budgie, and we loved him as a registrar. And then to my most recent head, in the photo on the right, Prof. Mariana Kruger, feisty, strict, but with a heart that absolutely is for children and child health and really pushing the clinician scientist agenda, and I've inherited this from her. And then Prof. Donald and Prof. Skuman is going to not like me for this. He's sitting in the middle. We're sitting in front of the Taj Mahal, and Ronald van Toren said, that photo is meant for romantic people, but it's the only photo that I had of the three of us sitting together. But Peter Donald and Johan Skuman, they considered by the world as the grandfathers of TB meningitis. Really good clinicians, examined well, and so methodological in their research. And I think this definitely rubbed off on me. And then Ronald van Toren also, if you want something to be formulated, a question, sometimes we go to him. We're a good tag team together. I write well, scientific English, and Ronald thinks well. So we are a good combination. And then just people that influenced me, Sharon Kling, as a mother figure, Louis Haynes, who passed away a few years ago, really took me under his wing. Rob and Nilda Beyers, Simon Skaaf, just for his absolute humility and methodological as a researcher. Ben Marais, who is on all my papers that I had for my PhD. And then Pierre Goussart and Lena Arabi and Mark Cotton, just the chats in the passage, speaking about patients and really getting ideas for things to do with research. So the burden of TB meningitis, I mean, why is this causing so much of a problem? So Karen Dupree did a study in 2019, and James Seddon, also one of my colleagues, did an earlier study. So they estimate that about 18,000 children develop TB meningitis each year. And Karen Dupree in her study estimated 24,000 children with TB meningitis. So out of those 24,000, 16,000 die. They die during admission. And for those that don't, almost 2/3 have serious neurological handicap. I mean, this is the most devastating manifestation of tuberculosis. And this is the first time that the burden has actually counted. It's a disease that's often been underfunded, unrecognized. I think that's changed over the last few years, just with lots of people in different aspects doing research and really presenting their case. So why does TB meningitis cause this much problem? So these are post-mortem specimens. Picture on the left, you can see there's a haziness over the base of the brain. And the second picture, all those little pink spots, they're all areas of stroke. So obviously, it's obvious that these two patients demised, and this dense infectious, we call it an exudate, forms at the base of the brain. So this blocks brain and spinal fluid flow and causes obstruction. It causes stroke. It affects cranial nerves and can directly affect the brainstem. And that's why there's so much pathology and devastation in TB meningitis. So the disease, to be able to tackle it really well, should be easy to diagnose. Well, it's not. There's only a few mycobacteria that you find in the cerebrospinal fluid, and probably our tests are 30% sensitive, so we're missing 70 just with the testing. So we rely on a good history, good clinical examination, we do investigations, and then we do microbiology, and we also rely on neuroimaging. So you really need your skills as a good clinician, because otherwise you're going to miss this devastating disease. So the clinical course of TBM is over days to weeks. The early symptoms are non-specific, and early on you can't distinguish this from the flu, and the only way to distinguish between the two is that flu will resolve within 4 days, 5 days max, and the symptoms of TB meningitis will go on. Often you don't have neck stiffness in young children, and if you have vomiting and no diarrhea, this is a red flag that there's pressure in the brain, and this is often missed. So we stage TBM from stage 1 to 3. In stage 1, there's fever, apathy, irritability, there's coughing, poor weight gain, and difficult to distinguish these from common conditions. By stage 2, there's neurological signs, and you can have depressed level of consciousness or have it preserved, and that we split stage 2 into 2A and B, and in stage 3 you have a comatose child with possible brainstem dysfunction and severe weakness. So what does this mean? In stage 1, TBM is completely treatable. The child sitting on the ball, in the picture on the left, has successfully treated stage 1 TB. This child is going to go finish school, he's going to be normal, he's going to have a family one day. The child on the right has stage 3 TB meningitis, has brainstem involvement, and this child either is going to die, 90%, or the other 10% going to have severe neurological disability. So this is what I encountered in the ward as a registrar, and working with Prof. Skuman and Prof. Van Toren sort of really stimulated my thinking. And this led to me embarking on a PhD with the title Improving Early Diagnosis of TB Meningitis in Children. So how it came about, I think Marceline van Voort came to visit. Johan Skuman told me, there's this opportunity that you're going to do as a PhD. I said yes without thinking, and for 2 years I regretted it, and then by the 3rd year it really kicked in and the bug bit. So I'm really thankful for the opportunity. I stayed in Bin and Visser Street, number 17. In the 2nd year, so I started going in 2012 for 6 to 8 weeks at a time. In 2013, Nicholas was 1 year old, and I had to do Skype conversations and was really homesick. That's a picture of Marceline in the top right, and then Marceline and her wife and Paul and Martijn in the picture in the bottom left, and lots of fun in between. So I worked hard, I promise, until 4 or 5, and then Martijn took it upon himself to show me where the spots with cheap beer and good and good oysters were, and the bottom right photo is of a place called Namke. I've been a few times. If you're ever in Amsterdam, the best duck, the best sort of baked oysters in the shell that you can find with really good Dutch beer. So thank you, Martijn. So my hypothesis for my thesis was twofold, that early diagnosis of TB meningitis can be improved by applying and refining a uniform research case definition, and that it can also be improved by enhancing rapid identification of TB meningitis. And the aim was to improve the early and more accurate diagnosis of childhood TBM by defining predictive clinical criteria and evaluating the diagnostic accuracy of new diagnostic methods. So it took a while, and then I really, the bug bit, so I published 7 papers for my PhD. I started with an overview of TB meningitis that I did with Ronald. I looked at case definition criteria, both retrospectively and prospectively, looked at meta-analysis of PCRs, I think it was the first paper in TB meningitis with gene expert on the CSF in a second paper, looked at the chest x-ray, what the utility is in TB meningitis, and also looked at diagnostic value of cerebral fluid chemistry. So good old plain protein and glucose actually gave better sensitivities than some of the fancy testing. And all of these have been cited widely. And this culminated in my defense in 2015 in September. I think it was 10 years ago. I got some photos a few weeks ago. I think my book, thesis book, I still have one copy at home and one on my desk, and also had a graduation Stellenbosch University in December. And yeah, just to mention, it's a very traditional ceremony. And on the left, far left of the photo is my brother, and on the far right is Douwe Visser. They were my paranymph. So this comes from the Middle Ages, when if you presented your research to the church, if they didn't like what you said, a few thugs would throw a few rocks at you. So you needed bodyguards. So I'm glad to say my bodyguards did their job. Thank you, Chadley, and yeah, Douwe as well. And just to say that I had a fantastic time spent in Amsterdam, and also just thank you to Marceline for being a mother hen and really looking after me and looking after the person first. I think the research sort of followed, and yeah, looking forward to collaborating for a while. So how do I think about research in TBM? Well, you start at the beginning and you have to look at the end. So you look at incidence and epidemiology, you look at presentation to health system. How do we diagnose TB meningitis? Which tools do we use? How do we treat TB meningitis? And afterwards, what is the neurodevelopment like when your treatment is done? So looking at neurodevelopmental tools to measure this. And also, sort of what sort of neuro rehabilitation is available. And with fantastic colleagues at Stellenbosch and also from abroad, I think we've started describing TB meningitis in children really well, from epidemiology to describing what happened when there was a global stockout of BCG vaccine, which we relied on, and we saw increased severity in TB meningitis, and really putting the burden and the severity of TB meningitis on the map. And I think in the last 5 years or so, there's been lots of funding opportunities. And not that you want to use sort of very descriptive terms to get funding. It really should be on the map, because if you address TB meningitis, you address tuberculosis. And also these days looking at what happens after TB meningitis treatment is done, because these patients come to our clinic and they're in wheelchairs, they have cerebral palsy. What happens down the line, that we don't just focus on 6 months of treatment and off you go. And you meet wonderful people along the way on your research journey with good collaboration. So this is Shane Mason. Shane Mason did a PhD also through Vrije Universiteit and Northwest University, and he is a guru. I think he sits in an office and just does NMR all day, spectroscopy. And he says so, he locks himself in the room. And we've had 18 publications looking at the finer detail of TB meningitis in urine and CSF, in children with or without HIV co-infection, looking at medication, amino acid, carnitine and whatnot. And there's many studies planned. So really tackling TBM to the minutiae. And also colleagues at Stellenbosch University and Vrije Universiteit looking at the proteins. So Douwe Visser is the picture on the left. He was my paranym. Really fantastic, bright individual. Also completed his PhD in TB meningitis, published the host immune response to tuberculous meningitis, where proteins clearly differentiated between TB meningitis and controls. And this work has been taken further with myself and Novell, who's in the audience, and Gerard Balsel, and a fantastic PhD student who has now finished his PhD, Charles Maniello. He actually, after his PhD, entered the graduate program for MBCHP at WITS. He's final year this year, and we must make every effort to get this guy back. He is absolutely brilliant. Humble guy from Venda, and really homegrown. And we've looked at protein biomarkers in CSF, in serum, looking at pathogenesis. How does this differentiate TB meningitis stroke from those without? And there's opportunities here, and there's lots of funding that has come because these can be developed into point-of-care testing. We have 2 patents that Inaugural has helped us with, where there's clear differentiation between TB meningitis and controls, and you can take this, so almost looks like a pregnancy kit with a few drops, and you can really take this to poor countries and get some added diagnostics for TB meningitis. And then also looking at treatment. So in children and adolescents with confirmed or clinically diagnosed TBM, we use at Tygerberg 4 years. This is based on Prof. Donald and Prof. Skuman's work. We use 6 months of 4 drugs at high dose, and the rest of the world used 12 months. So in a study, we compared, and our mortality was so much better. So our regimen was communicated in 2021 August by the WHO as an alternative to the 12-month regimen in a rapid communication. So they call it, everybody these days, they're doing trials on the Cape Town regimen. We just call it the treatment for TBM. But a clear difference, so whether it's our regimen that works or the fact that we look after the patients really well from a neurological point of view, I think we still need to find that out. And then outcome, what happens in TB meningitis? So Sylvia Chang looked at children with TB meningitis and what happened down the line. So almost 80% of children died with TB meningitis. And in the survivors, there was a 54% risk in motor impairment, sensory impairment, and cognitive impairment. And as you went up in stages, it got worse. So this is just a table with stage 1 on the column on the left, stage 3 on the right, and you can see so much more strokes, hemiparesis, and quadriparesis as you go up in the stage, and also with a mean developmental quotient or IQ, it really drops the worse the stage is for TB meningitis. So, I mean, really there should be focus on early diagnosis of TBM and getting TB meningitis at stage 1 where it's completely treatable. So I had a MSc Clin Epi student, Carol Liesel. So we looked at risk factors of poor developmental outcomes. So if you had a left-sided infarction, you did worse. And if you had bilateral infarction, you did much worse. So this is across global IQ, locomotion, personal, social, hearing, speech, hand-eye, performance, and so on. And the left side probably because it's the dominant side of the brain, but if you had right-sided infarction, I mean, you really took a hit. And the picture on the left, I mean, why is this so? So TB meningitis, if it causes stroke in the middle of the brain. So there's structures called the basal ganglia, and your motor fibers run through here. Your cognitive fibers run through here, and your limbic fibers run through here. So you have severe motor dysfunction, severe cognitive dysfunction, and attention and processing problems just because of one discrete area of stroke in the basal ganglia area. So as part of the TB meningitis work, you encounter wonderful colleagues. So myself and Ronald and Johan Skuman are part of the International TB Meningitis Research Consortium. We all seem to meet in very nice places. So the very first meeting was at Spear. I was a registrar in pediatric neurology, and somebody had to cover the ward, so I didn't go, and I had no intention at that time of doing any form of research. So Ronald and Johan attended the very first one, and then from the second, we've had meetings in Vietnam, in Lucknow, in India, in Oxford, and that's the picture on the top, and last year November in Bali. And out of this has come some seminal publications. So this was published last month in the Lancet. It's a clinical practice guideline for TB meningitis. So with this severe disease, you would think there's lots of evidence. Well, my job was looking at host-directed therapy and corticosteroids. I looked through thousands of articles. And the evidence based on randomized control trials they're just poor. There's so much room to do collaborative studies to look at TBM better. We've looked at the chemotherapy of TB meningitis and also just an overview of TB meningitis. And this is actually the paper of which I'm a co-author that is the most cited, I mean, far over 500 citations. And I think the top one is going to reach that as well. Sort of really getting all the heads together and sort of thinking really clearly about TB meningitis and what we need to do to improve. So pediatric TB meningitis research at Stellenbosch University. I mean, the first paper I could find was 1989, and Prof. Skuman can probably tell me if there's some earlier papers, but this is the earliest one on TB meningitis from that I could find on PubMed. And we've published 157 publications that have really informed the thinking of childhood TB meningitis. Started off by Johan Skuman and Peter Donald, and then later taken over by Simon Schaaf, and then Ronald van Toren, and I joined, I think, in the second half of this graph. And there's many more papers that are still going to come. Lots of collaborators, and the team has really grown. So this is a current funded study. NIH, I'm glad to say the funding has resumed, looking at stroke in children with TB meningitis. So these are just a few of the photos of the collaborators. But just to highlight two people that are co-PIs with me on the study, James Seddon on the top left. I mean, he's based in Cape Town. He's based at the Desmond Tutu TB Center. He's paid by Imperial College and works for free here. I'd like to get him registered by the HPCSA and get his clinical skills. So it's a win-win for us, and he loves being in South Africa. He's married to a South African wife. And then Nouvel Chagou, who's really taken point-of-care testing just to the next level. So the hypothesis of the study was that imbalances with endothelial and prothrombotic mechanisms and inflammatory pathways underlies cerebral infarction in TB meningitis. So we're doing CT scans, MRIs, and PET scanning, and then doing RNA and proteins, and then putting all of these together in letting AI help us a little bit with multi-omic study and really getting a good idea of how the minutiae of TB meningitis works, and doing studies at multiple levels. And thankfully, we on the not the naughty boy list anymore of the NIH, so it looks like we can complete the studies, but this is going to form the basis of many studies to come. So if you do family genealogy, you may recognize this. This is it's a fan chart, and this came from, and I'd like to, with the acting dean and the vice deans, not in work time, but really to try and answer where do I come from? And I mean, trying to explain to my children, and I could only go 2, sometimes 3 generations back. So you can see there's lots of gaps. The blue, I've gone the furthest, that goes right back until the 1100s. And then there's lots of gaps, and I mean, it really reflects South Africa being a very complicated country because the paperwork just stops. There's lots of fundacarbs, which means you were born here, but we're not sure of the ancestry. But all of these have played a role in me being me. And what I found while searching for this, my mom always told me about her sister that died when she was very young. So this is a picture of my grandmother, Wilhelmina. My mom is the little girl on the left. In the middle is my Auntie Noreen. She's passed away. She's my godmother. And then Joan Elizabeth. So Joan Elizabeth was born in 1948, and she died at the age of 7. And on the death certificate, I've highlighted there, she's died of tuberculous meningitis, paralysis of both legs, and she was ill for 6 months. And it really sort of serendipitous. I mean, this I found out a year or 2 ago, really puts what you do into perspective. And you ask yourself the question, what has changed since 1956? I think we understand the science a lot better, but the more science comes up, there's a lot more questions that pop up. For the patient in Genadendal, Western Cape, South Africa, I don't think much has changed yet. All aspects of the health system, from the micro level to macro to global health, needs interrogation and improvement, because that description of being ill for 6 months could have been one of our patients in the ward. So we really need to focus on the social determinants of health and nutrition. If you look at the old papers from Brooklyn, Germany, and France in the late 1800s and 1900s, their TBM looked exactly like ours. And what has changed? There's better housing and better nutrition in the last 100+ years or so. So we really need to focus on this. And this map puts into perspective, this is a map of Cape Town looking at sort of areas with socio-economic risk. So the red is, I I mean, those areas are sort of terribly off. Orange, slightly a little bit better, and yellow, you're doing okay, you just have enough food. And this happens to fall in the drainage area of Tygerberg Hospital. So these are the children we see, and we really need to focus on this. So I think health system renewal and improvement is part of a health system. We do it all the time, so we continuously need to interrogate. Early diagnosis is important, and early treatment. What is the best treatment? That we still need to figure out, and I think we're well placed at Stellenbosch University with people that can actually do pharmacokinetics and metrics and dynamics in children, and not just downscale drugs from adults. So we really need to focus on the children. We need to prevent stroke. This causes all the trouble in TB meningitis, and there may be therapy that's worth trying, and I think we'll plan an RCT in the future. And then also integrating all those TB programs with long-term multidisciplinary care, so that when you finish your treatment, it's not bye-bye, off you go. We really need to keep these children in the system. So do we search for Sugarman or Neverland? I think we have to search for both. Sugarman was found. Neverland, I'm sure it was just the wrong drug, so we need to focus on the right things. So as a baseline, we need to increase funding for TB prevention. We need to foster leadership in the space. We need to implement social protection programs, be advocates for children with TB and TB meningitis, build and sustain local capacity, plan, implement, and scale up interventions for TB prevention, which I think we're doing well in the Western Cape. Children and adults need increased access to optimal TB care. We need to strengthen implementation of integrated, people-centered, family-centered, community-centered strategies as part of primary health care. We need to be meticulous with our data, and we need to present this data and write it up and really change what we do in TB meningitis. And we really need to support research and development. But we also need to focus on the brain, the blood-brain barrier, all the omics, from looking at DNA, RNA, proteins, and metabolomics. We really need to understand how TBM works, because if it's been around since 2000, probably longer than 2400 BC, I think maybe it's long enough so that we can have a breakthrough. I'm hopeful. I think what was missing in my thinking was looking at TBM as an isolated event and then interrogating the system. So the photo in the bottom right, this is a group of people. It's called the Movement for Child Wellbeing. So it started off with conversations in Anita Parbu's office with myself and Rudzani and Keith and Gio Perez, sort of really coming up with a plan to look after our children better. And I must say, and you can ask Keith over a glass of water afterwards, about how the Western Cape Department of Health and Wellness has really put children as their focus for the next funding cycle. And all of this is based on the life course approach, so starting from pregnancy and ending in geriatrics. So starting well, living well, ending well, and having a system that's run well. So if you look at TB meningitis, you have to plug it into this whole system to really address all the gaps that you can. So how does my research have beneficial effects for children by turning findings into real-world solutions? I can sit in an office and just do research and get a PhD and lots of papers, but it has to have impact. So I think my research has accelerated early diagnosis. There's many more studies we're going to do looking at biomarkers, and this will, with Novell's persistence, this will lead to point-of-care, low-cost diagnostic tools that are really going to be taken into poor areas. This research has driven treatment innovation, informing WHO guidelines and influencing global standards of care. At the bottom of this is all just ensuring equity of access for all children, whether you're from Khayelitsha, whether you're from Bitterfontein, whether you're from Granadendal, you should have the same access. Building sustaining capacity. I've taken over a department that with sort of really good fundamentals, and I've made it part of my 5-year plan to mentor the next generation of clinician scientists. So to ensure that all these innovations persist and they're embedded in the health system going forward. And then also, this research has allowed me to leverage partnerships and actively collaborate. And you have conversations at these meetings during a tea break or often over a beer, a glass of wine, and this leads to a paper that leads to other papers. So I became the executive head at the beginning of 2023. This is part of the team. There's over, I think about close to 150 people in pediatrics and child health, and then there's still the Desmond Tutu TB Center, as well as FAM crew. So being the executive head has given me opportunities to lead a large research-intensive pediatric department, integrating clinical care, research, teaching, and training, and really shaping a child-centered policy. It's allowed me the scope to think about and hopefully drive innovation with translational research for child health solutions, and also build sustainable capacity by supporting next-generation clinician scientists. We've got an endowment from the Bayes Foundation, and then there were some funding opportunities which we utilized from the FMHS to really support early career clinician scientists. And I think we probably have about, just from the department, about 6 or 7 pre-docs and lots more. I think we are at a third of our clinical department with PhDs. In 5 years' time, we'll be at 2/3. And hopefully this is going to extend, and that's not taking into account the Desmond Tutu Center and FAM crew. And being executive head has also allowed me to champion equity by addressing health disparities in vulnerable children. So what does this clinician scientist agenda allow you to do? You can drive health system renewal. You reconnect patients, teaching, research, and advocacy. They're not separate things. You start with the patient, do all the other things, and you take it back to the patient to close the loop. You can advocate to secure supportive policy and resources, and also create a cycle of innovation and improvement. And all of this leads to measurable gains in child health and well-being, which is what you want. So on that note, I am at 43 minutes with 2 minutes to spare. Thank you very much for giving me a chance to speak. And just to acknowledge my son who did the picture on the left and my daughter who did the picture on the right. And the picture on the left was during COVID. I'm wearing a mask and scrubs. I haven't been close to a scalpel in years, but I really appreciate the photo, and thank you very much.
Good evening, everyone. Thank you, Regan, for a wonderful overview of your career so far. My name is Ronald van Teuren. I've been privileged to be a colleague of Regan probably since 2003. And I think my role this evening is just to confirm that everything he has said is truthful. I think there's one discrepancy which I think is important to highlight, especially with regard to lemons or limes. He's not handing it out because of medicinal reasons. He's doing it to encourage gin and tonic tasting. So we go back from 2003. Regan was a pediatric registrar in our department. I think first impressions was of a very popular, likable person, a good work ethic, good clinician, and also he was always empathetic towards patients. And I think that's a very important aspect of being a good doctor. During his pediatric training, he expressed an interest to become a pediatric neurologist, and when the vacancy became available, we offered it to him. And another confession, training him as a pediatric neurologist, and Johan can attest to that, that was more challenging. Often he required prodding and subtle encouragement. And retrospectively, I found out that it was during this time that he was courting Galen, his future wife. And his romantic life took preference over his training. But eventually we got there, and I think Regan there wasn't a post available immediately, so he joined our general platform, but he still continued to help us out in clinics, in neurology clinic, which we appreciated. And when eventually Johan retired after we worked together for 10 years, which was a big privilege, and now then Regan obviously was appointed in his position, and we've also had the benefit, I also had the pleasure of working with Regan for 10 years. It's so important to work with someone that you're compatible with. You know, we became friends. We share strengths and weaknesses. You spend 8 hours with a person. You know, we start off drinking coffee, we discuss complicated cases, then we do clinics together, ward rounds, research, outreach. So it's very important that you have a good working relationship, and that we indeed had. I think in that time, the 10 years that Regan was a pediatric neurologist, that's when his research really took off. And obviously, you can look at the PowerPoint to see what he's achieved so far. His 8 index is shooting up. He's very good at collaborative research. And very important as well as he's doing research on a very relevant topic, TB meningitis, which is still burdening on our population. When the executive head position became available about 3 years ago, I was a bit selfish. On the one hand, I hoped they didn't get it, because then we can continue our working relationship. On the other hand, I knew that he had all the skill sets required to become a good executive head. And he's been my head now for 3 years, and once again, it's been a wonderful working relationship. I think what is also important to appreciate is that Regan is not yet 50, very young, and he still has 15 years of leadership and career ahead of him. And I suspect if he's going to retire at 65, he's going to give another talk, which will be even more impressive than the one he's given today. So Regan, well done. We're all proud of you, and continue the good work.
Thank you very much. So Professor Solomon's indicated that if there are 1 or 2 questions, he's willing to answer any questions. Maybe you can just indicate if there's anything anyone would like to know. Doesn't look like it. So you've been obviously been very clear. Thank you. Okay, if there are no questions, then I'm going to hand over to Professor Koopman. Thank you.
Colleague Regan, I would like to call you back to the front. I acknowledge Acting Dean Nico G. van Pieterse, Registrar Brunel Retrieve, Deputy Dean Karen Baikes, Deputy Dean Therese Fish, management of the faculty, HODs, executive heads, colleagues and students of the faculty and of other faculties at the university and of other universities. We acknowledge alumni, emeritus colleagues, societal partners of the university, guests like, amongst others, Mpo Tutu and Marceline, and especially we acknowledge the friends and family, the mothers, the parents in love, the spouse and the children of Prof. Regan Solomon, Kayla, Nicholas, Selina, all protocol observed to be truly South African. Colleague Regan, my mandate is to present this certificate to you, and I do it on behalf of Senate. We know Senate is the central academic body of the university. This certificate confirms that you are a full professor of Stellenbosch University. Full professor is the most senior academic position at the university. Our staff, our students, and especially our full professors, are driven and guided by the values of Stellenbosch University, the so-called e-care values. Excellence. Excellence, which means I optimally live up to my own calling and my own telos and purpose in terms of my own potentialities and opportunities. In your person, colleague, and in your work, we see excellence. We also see joy in you, which tells us you do not achieve excellence through performance anxiety, but through performance joy. Now that's great excellence. The second value, compassion. Compassion is about concern and care for others. And we heard tonight also how Prof. Ronald responded here to say, he sees in you empathy, the capacity to feel yourself into the skin of others, and sympathy to feel with others. But also thirdly, interpathy, to say I think myself and I feel myself into the skins of those from other traditions and cultures and backgrounds and even age. You work with the youngest in our midst, with our children. And we see also your empathy in you being a core member of the Western Cape Child Wellbeing Movement. Accountability is the third value. Tonight you gave account of what you're doing, of your work, your actions, your practices. And of course, accountability also implies there's transparency, as we could see, and there's truth and truthfulness, trust and trustworthiness. And we saw tonight a colleague who's embodying accountability and trustworthiness. And the fourth value, respect. Respect simply is to put on your spectacles again. Look again. Think again. Consider again. Recognize the dignity and worth, the esteem and value, the honor, the splendor of other people and of other creatures, especially of those whom you work with. Consistently ask whether my actions advance dignity in personal, professional, public, and planetary domains. And our e-care values conclude with equity. We heard tonight you use the word equity more than once in your presentation. Equity, which comes from the Latin equitas, which means we seek for societies where there's equilibrium, where some don't have too much and others too little. We seek for societies of fairness to all. And equity also means I avoid extremes and I try to live with balance, with evenwig, with level-headedness, level-heartedness, and level-handedness. And we heard you say tonight, we must, to make progress, also focus on the social determinants of health. And that was very, very powerful in our context. Prof. Regan, in your lecture tonight, you reflect on how your own experiences, your pediatric patients, your surprising family discoveries have shaped your understanding of childhood tuberculosis meningitis. You discussed the first descriptions of TBM centuries ago. You took us on an exciting tour, the current understanding of TBM, and what, if anything, has changed since those early descriptions. You describe your collaborative role in epidemiology, improving early diagnosis, understanding complications, and biomarkers, developing better treatment options. You reflect on TBM from a global child health perspective, and you share your thoughts on how current research can have beneficial effects for our children by turning findings into real-world solutions. Colleague, your work indeed makes a healing impact on society, especially on the most vulnerable ones in our society. So collega, ons wens jou geluk. Ons eer jou, and we look forward to keep on journeying with you. Colleagues, can I now also on behalf of the acting dean invite you, we will outside enjoy that glasses of water that Prof. Regan referred to continuously. We will all stand and we will give opportunity to colleague Regan to lead us out, and then the rest of the procession will follow, and thereafter you can follow us out.